We're taking this, 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 we're taking with a pinch of salt.
Hello, ladies and gentlemen, and welcome to another episode of A Pinch of Salt, the podcast where we try to answer difficult clinical questions with as clear as possible answers. My name is Andrejko Bernet, and this is the podcast on ANCA vasculitis. So you can expect to hear about the new KDIGO guidelines, some information about avacopan, difficult cases, plasmapheresis, and rituximab. We're very lucky that we have with us today Professor Vladimir Tesar from the Prague University, and he has a long-standing interest in ANCA vasculitis, and also was one of the leading authors in the new KDIGO guidelines, so he's a perfect guest for us. Welcome, Vladimir, to A Pinch of Salt.
Yeah, thank you very much for inviting me.
It is our pleasure. So, you've followed vasculitis for quite some time. How do you see the management changing in recent years, and what's the hope for the near future? What are the major changes that are reflected in the new KDIGO guidelines?
I think that the most important breakthrough during my life was the introduction of rituximab in 2010, 2011, because until then the patients were treated repeatedly with cyclophosphamide with very serious toxicity. And now we have something which is much safer and similarly effective and works in most patients. But on the other hand, it in some way limited the further research activities in the field, because rituximab was so successful that it was quite difficult to compete with it. And we are now happy that there is something new, and something new is avacopan, inhibitor of C5a receptor, which was shown to be effective in ANCA-associated vasculitis as a kind of replacement of high-dose corticosteroids. And I think that what we currently still are looking for is the best place for avacopan in this setting. And I'm happy that there are some other drugs tested in this area, and I would specifically mention a clinical study with anti-claudin antibodies, in which we are also involved, which could probably help in healing crescents and limiting the degree of kidney fibrosis, especially in patients with advanced kidney disease.
So the major changes in the KDIGO guidelines are probably related to avacopan, right? If I'm not mistaken.
Yes, of course. And as you already mentioned, avacopan is a relatively great breakthrough, something new after more than 10 years. But there are some unclear questions which were not adequately answered. Of course, the problem is that avacopan is a very expensive drug. The problem is that we have no data until or beyond 1 year, so we do not know if it makes sense to treat the patients for a longer time, if it prevents relapses. We do not know what are the long-term consequences, because in advocate study, avacopan was better than corticosteroids, but corticosteroids in really low dose and finished within half a year. During 1 year follow-up, but it may be too short. And based on previous experience with, for instance, lower doses of cyclophosphamide from Cyclops and Cycazarem studies, we are still unsure if this treatment will be similarly effective after 2 years and 3 years, because there is still an option that there may be higher rate of relapses in patients treated with avacopan. I hope it is not the case, but it can be solved only by longer follow-up of these patients who were treated with avacopan as induction treatment. And then probably one important point that the approach to avacopan is changing, because it was originally introduced as a steroid-sparing drug. But we now see, but I must stress from secondary analysis, that it is the main point is that it probably spares kidney function. And there was a much better response in terms of recovery of renal function compared to high-dose corticosteroids. So it could be given probably especially to these patients with advanced kidney disease. But I must say that we would need to have a really large randomized control trial with primary endpoint recovery of kidney function, and not rely only on secondary analysis of advocate trial. And the second point is that as avacopan is really expensive, It is difficult to imagine that we use it in all patients with ANCA-associated vasculitis, and to define which patients may benefit most is not so easy. It was stressed by my colleague Benjamin Terrier that we have no data that it may be better, for instance, in frail patients. It's only an idea. And of course, I would use it especially in those patients who were already treated with high-dose corticosteroids in the past, or in relapsing patients, or in diabetic patients, obese patients. But it is really uncertain which groups really should be treated. But I think that it will gradually expand, and as there is probably no chance of having a randomized control trial with avacopan very soon, we will rely mostly on data from real life.
So when you say that the benefit is not just that you don't have the side effects of corticosteroids, but it might be better at preserving kidney function, and you mentioned that you would use them in advanced kidney disease. By advanced, do you mean disease with a lot of already chronic changes in the biopsy, or do you mean by advanced, do you mean something that is very acute, something with a lot of crescents?
Good but difficult question. Of course, it makes sense that it could be effective, especially in those patients with active disease. In chronic disease, probably you have no chance to modify the course. And the problem is that there are data coming from real life that it may work even in patients already on dialysis. But these patients were also treated with many other drugs, and the contribution of avacopan is difficult to assess. So we really need more data.
Again, when you say successful in patient on dialysis, do you mean successful in the kidney part, successful in the sense that they're not on dialysis anymore?
Yeah, they recovered, and recovered once again independent kidney function.
Okay.
Yeah.
So the new guidelines still advocate treatment with plasma exchange in cases of severe kidney or pulmonary involvement. And also, as you mentioned, rituximab is now the cornerstone of therapy, but it is removed with plasma exchange. So according to some data, the vast majority is eliminated after 3 procedures. Do you adapt your induction with rituximab in patients treated with plasma exchange? And if so, how do you adapt it?
In fact, I probably start with rituximab. We do not use rituximab in patients who are treated with plasma exchange. We start with rituximab only at the end of plasma exchange course. So in these patients, we would start with cyclophosphamide. And then we can probably, with the second course of cyclophosphamide, we could go for first course of rituximab and then proceed with rituximab. This is one of the options. In fact, we would then use the similar approach as it was in Ritux trial, combination of short-term, two pulses of cyclophosphamide with follow-up treatment with rituximab. But combining monoclonal antibodies with plasma exchange really doesn't make sense because, as you said, it is removed and it may not be effective. And concerning the use of plasma exchange, we were always fans of plasma exchange, and we still do that in some patients, but I must admit that the real evidence for plasma exchange is limited. Definitely the indication is the combination of the positivity of ANCA and anti-GBM antibodies, which is quite rare but not so rare, and these patients should be treated with plasma exchange. And then I think that we have now more data for patients with advanced kidney disease. So we say MEPEX-like patient based on the previous study called MEPEX, because based on the meta-analysis of the different studies, it seems that in these patients, plasma exchange may really work and at least for a limited time improve renal function. And we have very limited data for patients with alveolar hemorrhage. Unfortunately, there was a sub-analysis of pegcivastral dedicated to pulmonary hemorrhage, and even in patients who are hypoxibic, there was no apparent better survival or better recovery in those patients who were on plasma exchange. So for me, we should treat those patients who have advanced kidney disease and active changes in the kidney biopsy and probably high titer of ANCA antibodies. And in this area, I think that one of the reasons why plasma exchange doesn't work so well may be that in fact the decrease of ANCA is quite slow. We have now nice data from phase 2 trial for anti-GBM disease, and this is using the IgG endopeptidase, imlifidase, and I think, and in these patients, especially the patients with alveolar hemorrhage, possibly using imlifidase could be a breakthrough, but of course it should be tested in a randomized control trial, and I'm not aware of the trial with this drug in this field.
So you mentioned patients who have concomitant ANCA and anti-GBM, that they're rare but not so rare. So I suppose that in all ANCA patients with a clinical picture of RPGN, you also check anti-GBM antibodies, right?
Of course, in all of these patients.
All of these patients, yeah.
And we do that on so-called statin basis, so we have the result within several hours.
And when you mentioned giving the second dose of cyclophosphamide, in cases where you do plasma exchange, is that after 2 weeks?
After 2 weeks, approximately 2 weeks.
Approximately 2 weeks.
Yeah.
So some patients with active vasculitis also might have concurrent infections. You might, or maybe you're not completely sure if there's a bacterial infection, or perhaps you have very significant or concrete evidence of a pneumonia, bacterial pneumonia at the same time. So what do you do in cases where you believe delaying immunosuppressive therapy might be too harmful? Some have used initially, before the bacterial infection is treated, IVIG to gain some time. How do you react in these situations?
It is a very difficult situation because we often see patients with alveolar hemorrhage and in the same time pneumonia. And they are, of course, this is of course a very life-threatening disease, and they may die quite easily. And it is difficult. Of course, these patients can't be treated with cyclophosphamide. They can be treated with high-dose corticosteroids. This is what we definitely do. And if the patient stays on high-dose corticosteroids, it is a kind of delay, and he is prevented from the progression of the disease in a similar way as if he is treated with cyclophosphamide. So this is the easiest way. And then until recently, we believe that plasma exchange is quite safe in this setting, and the patients were treated also with plasma exchange, but now we have data from meta-analysis that plasma exchange increases the risk of infection, so it is a bit doubted. And but
unless
still,
perhaps you give IVIG at the same time.
And the concern in IVIG, yes, we have very limited experience with intravenous immunoglobulins. I mean that the major problem of IVIG, which we used mostly more than 20 years ago, is that the effect of IVIG is quite unpredictable. It works sometimes quite well, and sometimes there is almost no effect present. And of course, you have very limited data that there is any immunosuppressive effect of IVIG in this setting. And of course, you have some data that it may be good in those patients who have low IgG but below 6 gram per liter, which is not the case in most of these patients.
Yes,
so I'm a bit doubtful.
So you've mentioned that rituximab was a big game changer, as they would say, in ANCA vasculitis, and really immunosuppressive therapy nowadays is mostly successful. But in some cases, like you mentioned, severe pulmonary hemorrhage, or the ones I've seen were usually very young patients, either a child or an adolescent or somebody in their 20s, it can be very resistant to treatment. It can explode very severely. How can one react when the patient is not responding to steroids, cyclophosphamide, and rituximab, or both at the same time?
So it's a very difficult situation because, in fact, we have no clear idea what to do. And avacopan may work, but we have very limited data that it works. And as I said, it is usually argued in the setting where many other drugs were used, and so you do not know what is the exact contribution of avacopan. And possibly it may be also the case for using once again plasma exchange when other treatments do not work. And I think that we would need something new from some other glomerular diseases. We have some experience, for instance, with obinutuzumab, which could work not only in those patients who have anti-rituximab antibodies, but it should be better than rituximab as it is in malignant lymphoma. But it is only speculation because I am not aware of any data on that, but we have now some data from other global diseases that it really works, and this is something which is available for some patients not responding to rituximab, so this may be one of the options. Yeah.
Perhaps one would think that perhaps in a life-threatening pediatric, for example, disease, not necessarily pediatric, but for example, and you've alluded to that already, maybe imlifidase might be the lifesaver.
Imlifidase may be a lifesaver. I mentioned that, but unfortunately we have no data, and for these patients it is not available at all. So even not that it is off label, but it is not available.
Yes,
so
yes,
the
I know.
problem is that we can't use it. But for the future, I believe that it
will happen, right? Okay, that was very good. Thank you very much for explaining these difficult clinical dilemmas. Now to the tough question, which is which book, 2 songs, and luxury item would you take to a desert island?
This question is by far the most difficult.
Yes, I know.
And I am a great reader for the whole of my life, and I am very much omnivorous. So I'm reading everything. Usually I read several books in the same times. But in fact, from the point of view of the classical literature, I am now mostly reading detective stories and sci-fi, because it's probably a better chance to relax after my work.
Sure.
So I like dystopic stories by Philip Dick, and I like detective stories by Shari LaPena or Peter May. So it is not my recommendation, it is only an information that it helps me possibly.
Yes, but if it helps you, it could help somebody else, exactly.
Yeah, and concerning songs, I'm very traditional, so I like some national songs from southern Bohemia, where I was born, and I also like something from the 60s, such as Beatles.
What's your favorite Beatles song?
Possibly something like Yesterday, and Michelle is a nice song. Yeah. And the last question is the most difficult one. What luxury I could take with me to the desert island, and if I consider what is the major luxury I have, is probably my wife. And she cares for me all her long life, so I would be completely lost in the desert island without her.
That's nice. I think I can relate to that a lot. I can relate to that completely. So great answer. Thank you.
Thank you,
Vladimir. Thank you for doing this with us. It will surely be helpful to our listeners. Thank you for joining us, and have a good day.
Thank you very much for inviting me.